Thank you, everybody, for joining tonight's Living Well with Thyroid Eye Disease patient and caregiver virtual education event. My name is Susan Hepworth. I'm with the Vision Health Advocacy Coalition, and I'll be hosting tonight's webinar. I am pleased to be joined by Layla Lohmann, our patient advocate, and Dr. Holly Chang, coming to us from Seattle, Washington, and Layla's coming to us from Dallas, Texas. So just quickly run through the agenda. I'll give a very brief introductory remarks and the welcome, and then I will do a moderated Q&A with Layla, our patient advocate. Following my discussion with Layla, we will hear Thyroid Eye Disease 101 from Dr. Holly Chang. Following Dr. Chang's presentation, we have allotted time at the end just for question and answer from our attendees. Following the question and answer, I'll give a couple of minutes of closing remarks, and that will wrap up this evening's program. The Vision Health Advocacy Coalition is a coalition of organizations that promotes patient-centered policies that make devices, therapeutics, and other treatments available for people living with a variety of different vision conditions. Obviously, tonight we're going to be talking about thyroid eye disease. We would encourage you to connect with us on social media. You can find us at visionhealthadvocacy.org. You can also find us on Facebook and Twitter at Vision Advocacy. And lastly, the important part, knowing how it is that you can ask a question. You'll see a little Q&A box at the bottom of your screen. Once you click that, you'll see the Q&A box appear. Feel free to type in your questions at any time during tonight's program, during my discussion with Layla, or during Dr. Chang's presentation, and go ahead and hit send. There's no need to save your questions until the end. If you just go ahead and submit those as they come to your mind, I will add them to the question queue so we have those ready to go at the end of Dr. Chang's presentation. There's also a chat feature. Feel free to open that up. Leave us any comments, any questions, or any concerns. So I'm really excited. I'm going to stop sharing my screen, and then I'm going to ask Layla if she'll turn on her camera for us. And then we're going to go ahead and get started with our discussion. So first off, Layla, thank you so much for joining us, and thank you for being willing to share your personal experience with thyroid eye disease. Layla, you are on mute, so we'll ask you to unmute yourself.
Thank you for having me.
No problem. Okay, so Layla, I have a few questions, but first I just would like you to give us a little bit of background about yourself. People might be able to see you have something written on your scrubs right there. So just tell us a little bit about yourself.
My name is Layla Lohmann. I am living in Dallas, Texas, but I'm from Oklahoma. I'm a dentist. I've been practicing for almost 10 and a half years, and I love what I do. I actually do a lot of preventative, educated things for dentistry too, because I'm a very conservative dentist. I have two kids, almost 2-year-old and a 6-year-old. Husband and I have been together for 17 years. We enjoy pre-COVID traveling, restaurants, and movies. Post-COVID, lots of family time.
That's good. Yes, of course. Okay, and we're going to talk a little bit about your kids and thyroid eye disease because they kind of go together there in your pregnancies, but we'll get to that in a minute. So how many years ago were you diagnosed with thyroid eye disease?
So I was actually diagnosed with Graves' disease when I was 11 to 12, and I was diagnosed with exophthalmos, which is now considered thyroid eye disease, or it's a correlated. Dr. Chang will go more into that, but I was actually diagnosed with Graves' disease and then exophthalmos. And then as the time changed, it became like you could have thyroid eye disease without a thyroid condition or Graves' disease or Hashimoto's. So it was about, I'm 37 now, so do the math. I'm not good at math. I'm a science person.
Okay, so it's a while ago. Okay, so what were some of the first symptoms that you had that made you think something might be going on with my eyes?
Well, I mean, they were bulging. We're going to talk about it, but I've taken the Tepezza, but they were like this. I was like this, and I was skinny, and my mom was like, "I need to take you to the doctor." So we always thought, because I'm Iranian, so we always thought, oh, you're Middle Eastern, you've got big eyes. That's literally what they would tell me, but I actually had the thyroid eye disease condition.
Okay, so talk to us then about some of kind of these flare-ups that you had during your pregnancies that like sort of led you to need to really get your thyroid eye disease under control?
So I was on medication first. I had a thyroidectomy in 2000, and everything was pretty controlled until dental school. And then I got really dry eyes. So they had to plug my tear ducts because my eyes didn't close all the way. So then that was controlled for 6 to 10 more years. And I thought since I didn't have thyroids anymore, that my thyroid eye disease was gone because my eyes sunk back in a little bit, but I still had extra tissue. So I didn't think anything of it. But when when I was pregnant with my son, I guess the thyroid eye disease reactivated, and it manifested itself as headaches and double vision. And I started having lots of complications of, like, I would be looking straight and people would be double. So the thyroid eye disease apparently reactivated, which was rare, according to my ophthalmologist. And my son actually ended up coming early at 36 weeks because my condition was worsening and I possibly had issues that could be long term. And being a dentist, we weighed hey, he's 6 pounds, you're not doing well, let's go ahead and take the baby.
So how did that impact your ability to practice dentistry?
So actually, it's an interesting story. It doesn't affect me looking down. It was the muscles around my eyes that when I looked up, they were strained. So if I looked like this, everybody was double. So beforehand, I didn't realize I compensated. Like, I would just walk around kind of like this so everyone wasn't double. So, I mean, people were like, when we were taking pictures between my age of 30 and 36, I'd go smile like this. And they're like, no, tilt your chin down. And I'm like,
but I'm seeing double.
I know. Right?
Yeah. So then what was your course of treatment during your pregnancy and after your son was born?
So during my pregnancy, we did, they were trying to do steroids, but I was trying to avoid that because I was pregnant and it crosses the placenta. And so we did selenium. And then I had to wear a patch. I mean, there was a lot of random things that I had to do. And then after my son was taken, it decreased by 50%. Like, just the pressure and the weight, some things just kind of, the inflammation was decreased. So it took me about a year to get it back to normal, but like, instead of being double like this, it would be double a little bit higher. So like, it just got a little bit better. Then we did steroids, and we did my doctor was really conservative, and I appreciate that because it would have been orbital decompression and all the other surgical options. And one of those complications is blindness. And so I was like, I'm married, I've got kids, I don't need to see. I mean, I need to see for my work. So this is fine. My husband will still love me.
Yeah.
So, it was complicated.
So then you sort of got it under control and you got pregnant again. And what happened then?
So I first asked if it would happen again. I did my due diligence and asked, how rare is this to happen again? And he said it was rare to happen in the first time. It's even more rare to happen the second time. So during our journey, I had a couple of miscarriages and some other stuff, and then got pregnant again. So we think everything's fine. I did not have double vision. I didn't really have headaches. And then second trimester happens and it happens again. At which point, again, I'm wearing a patch. And it was horrible. Like, we would watch a movie and I'd have to like turn the lights down, and my husband would know I'd be like this in our theater, and he would be like, are you comfortable? I'm like, don't worry about me, we're doing fine. But I was sensitive to the light. It was bad. And then my daughter came at 36. My son came at 35.5.
Okay.
Because of my complications.
So I want to ask you, so before we kind of get to how you ultimately were able to find treatment that worked for you, I want to ask you about kind of the mental health and the psychological component of thyroid eye disease, because I know for many patients dealing with this, that's a major component to it. So just would like for you to talk a little bit about some of those feelings and experiences you had and how it is that you you dealt with those?
I mean, I definitely know when I was younger, it was called bug eyes, and that's very traumatizing to an eighth grader. And it was I had a good family. I have a twin sister. I grew up with it, and I mean, it is what it is when you're a kid. So that was hard. And then as I got older, I'm an extrovert. You can't tell. You just make friends and you live through it. Got the thyroid condition under control. So uh, I would be stopped randomly in grocery stores being like, oh my gosh, you have such huge eyes. Like, oh my gosh. And I was like, I already know that. Thanks. And so battling that was tough. Then, you get married, you do your thing, you don't think anything of it, and people bring it up. And I started going to therapy after having my son 6 years ago, just because I don't think my thyroid eye disease caused it, but my medications may have led to some kind of complications with my son, and he had to have some surgeries. And so I think everyone should get self-care now that I've gone through it for 6 years. So I think just talking to somebody out, and it just helped me let someone talk about, it's not all about my eyes. Like, people say stuff about my eyes to this day, even in my practice. And like, I have to like hold it in to not get defensive because they're not trying to be rude. But someone was just like, you're just so responsive and you're so reactive. And I'm like, what's a thyroid condition that I have?
Yeah.
So it's been hard, but and I didn't even know these types of groups were available till I met you. And it was because of Tepeza that it happened. That's how I met you, when they stopped that shortage time.
Yeah, so let's talk about the Tepeza. People on here may not know what that is. So you pretty recently were actually able to find a treatment that worked for you. So for those on the webinar who don't know, that the FDA did approve last year that the first treatment specifically for thyroid eye disease really helps with a
First
lot of the symptoms,
non-surgical.
and it's not surgical, and Dr. Chang will talk about it a little bit later. But can you just talk about your experience with the course of the treatment and how you feel it has worked for you?
Yeah, so this is the first non-surgical treatment for thyroid eye disease, and my doctor's been very conservative. And this, when it came approved in 2020, the summer of 2020, he was like, I was the first person he called, because I was still always having a little bit of double vision after it was controlled. But we just managed it because I didn't want to do anything surgical. And so I didn't realize how much pain and discomfort I was in until I got relief, which is the interesting part. Because I had headaches, and like it would have tension here, but you kind of just, you think it's allergies. You start making up excuses because everyone's tired. But so he got me in. I talked to, Tepeza's patient advocacies. We had to go through insurance. It's kind of a whole process of like 3 months to even get approval for the drug. I'm sure it's faster now since it's been out for a year. If you're off topic, tell me that. But then I started it in November of 2020. And it's infusions. So you go to an infusion center, at least in Texas, I did. They go over all of the positives, pros, cons, negatives, side effects, which I can talk about afterwards. And after the first one, I kind of think it was psychosomatic. I was like, oh my gosh, I think I feel better. And my doctor's like, yeah, that's not how it works. And I was like, okay. So then they did the second one. And then then I got a call at the third one saying that the Operation Warp Speed was going to stop hold on the drug. And I'm like, I'm sorry, I'm mid treatment, 2 of 8. And I'd already had my third one scheduled, so that was fine. And then they had to like fight to get my fourth one, because you were seeing more of the therapeutic effects after the third and fourth treatment. Just the studies have shown that. And I started to feel better. And then, so I had to stop treatment after my fourth session. And I was mad. So then I reached out to, I was writing emails saying like, this is absolute bollocks. I'm not even English, but I cursed. And then they said it might happen in the second quarter. The quarter happened, it started over again. So then I finished my course of treatment, and I have like, I like have no double vision, maybe a little bit of straining, zero double vision, less redness, less pain, less headaches. So it's really changed my life on sight. I have had some side effects. I've had like Charlie horses and cramping randomly. I've had nausea, a little bit of that kind of stuff, GI stuff. Then that's really just like the week after treatment. So it went away and then it came back. And then probably after the 7th or 8th treatment, I started having a little bit of hearing issues, and they're just recently finding out that there's slight complications for hearing, but it comes and goes. And so for me, sight was the most important thing. Everything else on that side effect list was, lo and behold, lower on my threshold. So I'm a huge fan of the Tepezza drug. It's helped me with my confidence. It's helped me with just quality of life that I didn't know I needed. So I'm enjoying it. I love it. And I would do it again in a heartbeat if it ever came back, or they said it would get better.
That's great. And I think that's a perfect note to end on, because the last thing I was going to ask you is, how are you feeling today? But I think you just encapsulated that there. So as Layla said, Tepezza did run into a bit of a drug shortage earlier in the year, and that was because the manufacturer that was making some of the parts for that medication did have to allot their manufacturing slots for the COVID-19 vaccine. And so that did present a problem, because we wanted to ensure that patients, who are mid-treatment could still continue to access that medication. And while, of course, we wanted to make sure that we were doing everything we can to produce those vaccines, we couldn't do it at the expense of other patients. And so luckily that was a pretty short-lived drug shortage, and then patients will be able to regain access again, just as Layla did. So Layla, thank you so much. We'll have you stay on, and then I'll turn it over to Dr. Chang, and then we'll do question and answer. So Dr. Chang, go ahead.
Okay, well, let me go ahead and share my screen.
Looks good.
Awesome. Okay, well, thank you to the organizers for inviting me to speak, and thank you, Layla, for sharing your journey with us. We're going to dive right into Thyroid Eye Disease 101. So Graves' disease is an immune system disorder where the body's own immune system is attacking its own tissues, including the soft tissues of the eyelid and the eye socket. And when the eye is affected, we call this thyroid eye disease. It also goes by many other names, but as the Supreme Court Justice, Potter Stewart once famously said about pornography, we just kind of know it when we see it. And when I'm watching Layla on screen, when she's animating, her upper lids shoot up, and we know that very kind of classic upper eyelid retraction is a sign of thyroid eye disease. So we'll talk more about that as the lecture goes on. So what we'll cover today is the epidemiology of the disease, the course of the disease, how it presents, how your doctors and other clinicians are diagnosing and monitoring or following the course of the disease. And then, of course, management, both during the active inflammatory phase as well as the inactive phase, where we're dealing with the reconstructive aspect of the treatment. So up to 2% of the general population has Graves' disease, and 50% of those people have clinically apparent thyroid eye disease. The other 50% probably have eye disease as well. It's just subtle enough that we are not able to detect it with the tools that we have clinically. So a quick back of the envelope calculation means that up to 6.6 million people in the US are living with Graves' disease. And that means over 3 million people have clinically apparent thyroid eye disease. Thyroid eye disease is 6 times more common in women than in men, and 7 times more likely to happen in smokers than non-smokers. All that is to say, you are not alone. Thyroid eye disease have affected prominent public figures like former First Lady Barbara Bush, rap artist Missy Elliott, and my own auntie has thyroid eye disease. So the disease course. It's important to know that the eye disease does not track with the systemic thyroid disease like Layla described in her experience. Thyroid eye disease can precede, coincide with, or follow systemic thyroid problems. The thyroid eye disease is self-limited. The active inflammatory phase is usually about 1.5 to 2 years. It can be longer in active smokers. And there is a reactivation that can happen in 5 to 15% of patients over their lifetime. Again, Layla is a good example of this. It usually occurs during times of stress, whether that's emotional stress or physical stress, hormonal stress. And we do see it in pregnancy, around, if the death of a loved one or, something stressful can bring on the reactivation. So among patients with thyroid eye disease, 90% of them have Graves' hyperthyroidism, but 6% actually have normal thyroid hormone levels. We call that euthyroid. 3% have Hashimoto thyroiditis, and 1% have hypo or low thyroid levels. So we've always understood thyroid eye disease to follow this trajectory. You have the active phase where there's inflammation, the disease is ramping up, and then at some point, 1.5 to 2 years, the disease burns itself out. So the inflammation burns out and you end up at some baseline, new baseline. That's not where you started, but there's no longer active inflammation. You are now dealing with the results, the after effects of all that inflammation. And that's usually when corrective surgeries are needed to rehabilitate the patient. So how do patients first present with thyroid eye disease? The most common presentation is upper eyelid retraction, where that eyelid muscle that normally lifts your upper lid is tight. And so patients get this very kind of classic staring or very intense appearance. Proptosis, bulging eyes. Strabismus, where the muscles that move the eyeball, so not the one that lifts the eyelid, but the ones that move the eyeball, those muscles get tight. And of course, the pain, the tearing, the pressure and congestion. So there's a wide range of disease activity, and the inflammation can be very asymmetric. Sometimes one eye suffers a lot more than the other. Patients can have good days or weeks and bad days or weeks. And 5% of thyroid eye disease patients can progress to optic neuropathy, where the nerve that carries vision from your eye to your brain suffers compression, and or the proptosis or exposure of the eye surface can be so bad that it causes decompensation of the cornea. The cornea can ulcer or even perforate. But that is to say 95% of patients do not develop vision-threatening disease. So here we'll get into a little bit of the nitty-gritty, a little more technical, what your doctors are looking at when they diagnose and monitor the disease. So to receive a diagnosis of thyroid eye disease, you have to have 2 out of these 3. Number 1, current or recent immune-related thyroid disease. And that can be Graves' hyperthyroidism, Hashimoto's thyroiditis, or you can have normal hormone levels and have what we call anti-thyroid antibodies. And I'll cover that in my next slide. So that's number 1. Number 2, typical ocular signs. That's the eyelid retraction, the proptosis, the things that we talked about in how patients present. Or number 3, radiographic evidence, usually a CT scan that shows thyroid eye disease, very classic enlargement of the muscles that move the eyeball around in a specific pattern. So 2 out of these 3 gets you a diagnosis of thyroid eye disease. And what are these anti-thyroid antibodies? There's the TSH receptor antibody, also called the TRAB or TRAB. the thyroid peroxidase antibody, and then the one that we most often use to diagnose and sometimes to monitor response to treatment, the thyroid stimulating immunoglobulin, or TSI. So if you see this showing up on blood work or in doctor's notes, these are the antibodies that sometimes can clue us in to thyroid eye disease or thyroid dysfunction, even when the TSH or the T3 and the T4 are within normal range. So now that we can diagnose the problem, how do clinicians talk to each other about the disease? How does your oculoplastic surgeon talk to the rheumatologist about the severity of the disease? Is it responding to treatment? And how do doctors and scientists communicate to plan clinical studies, clinical trials, and treatments? Well, we have to have a common language. We have to have a grading scale. There are a lot of different grading scales out there, but the one that we most commonly use in the US is the clinical activity score. And here it is. So there's a 7-point scale, clinical activity score, and a 10-point one to use for follow-up patients. So the 7-point score is related to pain. So if you go into the office and your doctor at every visit asks you, do you have pain or aching in your eye socket? Does it get worse when you look up and down? They're trying to find if you have points on that scale. And then the rest of it is related to inflammation of the eyelids, the surface of the eye. The follow-up scale, it compares your vision from one visit to the prior visit, eye movement, proptosis, etc. So the clinical activity score, 3 or above, indicates active thyroid eye disease, 4 or above if you're using the 10-point scale. But the patient is the one that actually has the most information. I have patients who can tell me down to the day when their thyroid eye disease started. They can tell me at every visit if they're getting better, if they're worse, or if they're stable. And that's because of this number, 17,520. That's the number of hours in 2 years. That's the number of hours that the average thyroid eye disease patient lives with active inflammation. So they know what their disease is, and the disease is more than just clinical symptoms. It impacts quality of life. So quality of life in thyroid eye disease was first studied in 1999. And since then, there have been a lot of different studies looking at quality of life. Sorry, 1997. Initially, general health-related quality of life studies compared patients who have thyroid eye disease, their quality of life, to patients who live with other systemic diseases. And they found that patients with thyroid eye disease actually report a worse quality of life than those who live with diabetes, COPD, congestive heart failure, and they have increased anxiety and depression. And I'll tell you, I mean, the only patients who routinely cry in my office are my thyroid eye disease patients. And I treat patients with cancer. I remove eyeballs, I take out eye sockets, but my thyroid eye disease patients are the ones who are routinely distressed. And I get it, right? We have mostly women who are beautiful. They're in the prime of their lives, just like Layla. And they now are dealing with a disease that's unpredictable and not only affects their vision, but affects how they look in the mirror to themselves and how other people see them and how other people interact with them. So it's not surprising that thyroid eye disease patients said, well, you know, these quality of life studies don't really capture aspects of my disease, my eye pain and discomfort, and how it impacts my social and my work interactions. So then people came up with thyroid eye disease specific quality of life surveys. The GoQual is the most well-known of these, and it was first developed in Dutch by this group. And it really, the questions focus, 8 questions focus on the visual impairment, 8 questions on the psychosocial effects. So they're really giving equal balance to the psychosocial impacts of the disease. And it's been shown to be highly reliable, and it correlates well with the clinical course of the disease. It's so good that it's actually been translated into multiple languages. And there is also a shorter TED-specific quality of life survey that's only 3 questions. It's quick, easy to understand, and it's a good screening tool. All right. So bottom line is the thyroid eye disease specific quality of life surveys give us valuable information beyond the clinical measures, and they're useful tools. So to identify unmet needs, right? Even if your eye looks stable, it may be that its impact, something's changed in the quality of life. And it helps us to treat patients in a more holistic way. Okay, let's move on to management during the active phase. That's the active inflammatory phase. And that phase we divide into mild inflammation, moderate inflammation, or severe. First off, it's important to keep the thyroid function normal. Even though the disease doesn't necessarily track with the disease in the body, we still want to make sure that the body part of the disease is normal. And that's usually treated with, accomplished with methimazole, radioactive iodine, or surgery to normalize the thyroid, what the thyroid gland is doing. A word about radioactive iodine. There is a small risk of worsening eye disease in certain patients if they take radioactive iodine. Those are typically patients who have active eye inflammation, or if they don't have active inflammation, but they have elevated TSH receptor antibody levels, T3 levels greater than 2 times normal, or if they're a smoker. And these may seem a little random, but they come out of different clinical studies. So that doesn't mean that these patients cannot have radioactive iodine if their endocrinologist decides that that is the best treatment for them. It just means that they're at a higher risk of getting worsening eye disease, and we treat them with some oral steroids starting just before the radioactive iodine, and we taper it over the course of a number of weeks to months. And it's a relatively low dose of oral steroids. So for patients with mild eye inflammation, that's clinical activity score less than or equal to 3, we definitely, and for any level of inflammation, we definitely want you to stop smoking, and also to stop or limit exposure to even to secondhand smoke. A healthy lifestyle, exercise, an anti-inflammatory diet, and lubrication of the eyes to help relieve any of the dryness and grittiness symptoms. So a word about lubrication, your doctor's going to say, oh yeah, use artificial tears, use artificial tears. Well, there's no specific brand. You can experiment, find the one that works for you. Anything that comes in a bottle has preservative in it. So you can use that up to 4 times a day. If you find that you are needing drops more than 4 times a day, like if you're using eye drops every hour, use a preservative-free eye drop, and those come in little break-off vials. You can usually get a couple more, or 2 or 3 drops out of each vial, so you can use that as the day goes on, but they don't have preservative in them. Use ointment at night, especially if your eyes don't close while you're sleeping. Other strategies is to put a humidifier in your bedroom to keep the environment more moist. And if your eyes really don't close at night, you may end up needing to create a moisture chamber with a goggle, or even just a saran wrap, with some Vaseline around the eye socket bone and a piece of saran wrap that goes across. So people have gotten very creative to try and help the pain in their eyes. I do put my patients on selenium, like Layla mentioned she took. Selenium has at a dose of 100 micrograms twice a day has been shown to improve the quality of life and slow the disease progression in patients with mild Graves' disease. And we usually have patients take it for 6 months total, because that's what the study showed. And so for our patients with mild inflammation, we just ask them to be patient. Things are changing, and we just have to support them through the changes until the disease burns out, and they usually do fine. So for patients with moderate and severe inflammation, the goal is to preserve vision and decrease the inflammation to minimize the after effects, right? If you just let this fire burn, when it burns itself out, you are left with a lot of damage. And so we want to try and limit that burning, that inflammatory phase, to ultimately have a better outcome. So again, the course of the disease that we're familiar with. And what we're trying to do here is really just decrease the intensity of that inflammation and shorten its duration. So hopefully patients can return to a more baseline that's more like where they started, rather than a new baseline that requires a lot of intervention surgically. So this is an exciting time for us as far as intervening during the active inflammatory phase. In addition to the watchful waiting and the traditional steroids, maybe radiation to the eye sockets, we have access to both nonspecific and targeted immune modulation drugs that target the specific inflammatory pathways in thyroid eye disease. So, when I do a search of the term thyroid eye disease in the PubMed medical literature database, there wasn't much happening for decades. And then since the 80s, and it's just gone on exponentially, the amount of research being published on thyroid eye disease. So I'm going to use that. I'm going to try and summarize the medical literature and give you the evidence that we have to answer some basic questions. So we've known for at least 15 years that if you're going to treat a patient with thyroid eye disease using steroids, IV steroids, so steroids given as an infusion, usually weekly for a certain number of weeks, is much more effective than oral steroids. Unfortunately, I still, on a weekly, monthly basis, have patients who tell me that their doctor is still giving them oral steroids. So it takes a long time for the evidence to kind of permeate into medical practice. But we know that IV steroids are more effective and have fewer side effects than oral steroids. What about radiation? So radiation kind of goes in and out of favor every 10, 15 years or so, depending on the studies. But we do think that radiation is effective for patients who have tightness of the muscles that move the eye. So if there's double vision or strabismus, which is misalignment of the eyes, I often will prescribe radiation, and it's a low dose radiation. It's not like chemotherapy, type of radiation. It's low dose radiation to the eye sockets, and it's more effective when it's given with the IV steroids. Then we have the immune modulating medicines that target specific inflammatory pathways in thyroid eye disease. The first of these is a drug called rituximab, or Rituxan. So rituximab inhibits the immune system's B cells, which are lymphocytes, they're white blood cells. And the drug is used to treat certain types of blood cancers, lymphomas, leukemias, and certain autoimmune diseases. We have a lot of case reports and some case series. So patients who have been with thyroid eye disease treated with rituximab who have responded well. And we have one small clinical trial of patients being treated with rituximab that was actually stopped early because the patients who were treated with rituximab did so much better than those who were treated with IV steroids. So rituximab is one of these immune modulating therapies that we have available to us. Tocilizumab, which is also called Actimra, is another one. It targets the immune system's IL-6 cytokine, which is another inflammatory pathway. It is a drug that's, again, used to treat certain cancers as well as autoimmune diseases. And just like rituximab, we have some case reports that it works. We have one clinical trial of patients treated with tocilizumab that had good response compared to placebo, but the response in proptosis, unfortunately, was not sustained. Then we have teprotumumab, which is Tepezza. That's what you heard Susan and Layla talking about. And I mean, this is truly a game changer, right? This is the first and only FDA-approved medication to treat thyroid eye disease. It's given as an infusion, 8 infusions, 3 weeks apart between each one. It has a very favorable side effect profile. It's the side effects are much less than even IV steroids and certainly some of those others that I mentioned. And it's the only medication that decreases inflammation and gives sustained proptosis reduction as well as improvement in the double vision. It does have a hefty price tag, so it's difficult to get it approved through insurance, although I hear that, it varies by region in the country. So let's put it all together. We want to restore the euthyroid state. So we want to either use chemical or surgical thyroid ablation, right? Methimazole, radioactive iodine, surgical thyroidectomy, to get the thyroid levels back to normal. There's a small risk of worsening thyroid eye disease after radioactive iodine in patients with certain risk factors, and we just treat them through that with a low dose of oral steroids. For patients with mild thyroid eye disease, stop smoking, healthy lifestyle, exercise, anti-inflammatory diet, lubricating the eyes, selenium 100 micrograms twice a day for 6 months, and watchful waiting. Moderate to severe thyroid eye disease, you're going to do all of that. Add teprotumumab. First line is if you can get it. Unfortunately, the insurances often will require that patients try and fail a course of IV steroids or one of these other drugs, rituximab or tocilizumab, before they approve teprotumumab. And that's just part of the reality that we live in. Orbital radiation, I like it if there is significant eye muscle scarring and tightness and double vision. For those 5% of patients with vision threatening, rapidly progressing thyroid eye disease, I admit them to the hospital. We do IV steroids every 6 hours, and if they do not have a significant response within 48, maybe 72 hours, we're taking them to surgery and urgently decompressing the eye socket. So let me talk about, we'll wrap up with management during the inactive phase. So now we've gone through the inflammation, we're left with whatever the disease left us with, and it's time to go ahead and try and restore patients to their pre-disease state as much as possible. So surgery happens in steps. We do if orbital decompression is needed to bring the eyes back into the eye socket, we do that first. Why do we do that? Because when we move the eyeball around, we can cause double vision. So we wanted that to be stable, and then we do eye muscle surgery to treat the double vision. Once that's stable, we do eyelid surgery to fix the intense staring look, and then there's cosmetic enhancements. Well, how much time are we talking about, right? You have a patient who just lived for 2 years with this, and now you're saying, okay, we have to, do your orbit, wait till you're stable for 6 months before we do your orbit surgery. And then we wait till you're stable from that for 3 months before we do muscle surgery. And then lid, so you can, this is a big timeline. And there are ways to compress that timeline. Sometimes if I do an orbital decompression on one side, I'll start to fix the eyelid on the other side, or both, to just kind of get patients a little bit more relief and get them some encouragement, so that they can see improvement earlier. And same with cosmetic enhancements, which I'll cover. So reasons for orbital decompression. The muscle and fat tissue behind the eyeball have expanded with this disease. It's pushing the eye forward. And the swelling causes pressure and pain. So those are all reasons that we want to decompress the eye socket. This is a good demonstration of the thickening, where the arrows are pointing, of the muscles that push the eye forward. You can see, compared to the normal muscle on the other side, how thin and slim that muscle normally is. So that creates a lot of pain for patients. Bulgy eyes can be irritated, dry, and of course they change the patient's appearance. And the goal is to reduce that pain, the congestion, and the bulging. So in preparation for surgery, your surgeon will often it's usually CAT scan, it's usually a CT scan, to look at the bone structure of the eye socket, figure out where the bone can be removed or diminished to create more room for the eyeball. And when we do orbital decompression, we kind of think of the eye socket like a box or a room, and we want to take out walls safely to create more room for the eye tissues to sit in. And so how much decompression we do depends on how far we need to bring the eye back in, how much room we need to make. We think of this as walls that we remove. So the first wall is actually just orbital fat. If I only need 1 millimeter or 2 of decompression, I actually don't need to take any bone. We can make a scarless incision, so a hidden incision, go in, remove some fat, and bring the eyeball back. If I need more room, I like to take the lateral wall first. The lateral wall is the one kind of out here towards the ear. I like taking the lateral wall because there's a lower risk of causing double vision, about a 2% risk. If I need even more decompression, I will go ahead and take the medial wall along with the lateral, but that increases the risk of displacing the eyeball, shifting the eyeball, and causing double vision. So the risk becomes about 7 to 15% of patients who didn't have double vision before the decompression will have double vision after. But you can see removing the bone and the fat allows the eye to sink back into the eye socket and just having a much more relief from the congestion. So what do these incisions look like? Are patients disfigured? Well, no, we try and use elegant hidden incisions. We can usually access pretty much 270 degrees of the eye socket through hidden incisions. And we don't decompress on the roof because that's brain, right? So we try and stay away from that. It's a bad day if I see brain. So to access the lateral wall, we can make an incision hidden within the crease of the eyelid. To access the medial wall, we can make an incision hidden within the mucous membranes of the eye. And then the lower wall, we can make that same incision on the back side of the eyelid. So it's all really elegant. And when patients heal, you actually don't have a lot of scarring or disfigurement. So I do my decompressions one side at a time. Some people do bilateral, I don't. I do one side at a time, and it's usually within the same month, just to keep the timeline going and keep progress moving. Sorry, my screen just is not that responsive. So we're gonna wait for the next slide to come up. This is a woman with relatively mild right-sided proptosis. So just made an incision, hidden incision behind the lower eyelid, took some fat out, okay? This is, again, a transconjunctival, so hidden incision, decompression, and then I also went in at the same time and lowered the upper eyelid just to, again, give patients some encouragement so that they can have some visible improvement as we move forward the various stages. Oftentimes the congestion and just that aching pressure improves a lot after orbital decompression. So after we're done with the orbital decompression, if it's needed at all, we can move to eye muscle surgery. Now, I do not do eye muscle surgery. I don't do strabismus surgery, so I will send my patients to an adult strabismus surgeon, so somebody who normally deals with eye alignment. Like I said, double vision can occur before or after be caused by the decompression. That's why we do the eye muscle surgery after the decompression. And during that time period, which could be 6 months before you actually get surgery to realign the eyes, patients are living with double vision. So we have temporizing measures. We have prism stickers you can stick on one lens to help shift the image so that you're not seeing double. You can just cover one eye, and it can be either eye. If your vision itself is good out of both eyes, it doesn't matter which one you cover, as long as you're seeing out of one eye and eliminating the double. Or we'd have people put tape over one lens to cover up the image. And the goal is to create a single tunnel, a tunnel of single vision that allows you to go back to regular activities, right? So you're not double looking straight ahead or looking down. Those are the two most important positions. You may always have some double vision when you're looking far off to the sides, but as long as you are single in the positions that matter the most, straight ahead and down, that's considered successful. So muscle surgery, most people I think still do them with adjustable sutures so that they actually can, as the anesthesia wears off and you're awake and you're moving your eye around, they can still do fine tuning and adjustments to realign the eyeballs. It's really quite remarkable what can be accomplished. So after that, we reposition the eyelids, and that's when we're fixing that retraction, that tightness of the upper lid, and it also happens in the lower lid too. So by bringing down the upper eyelid, it just softens the patient's appearance, makes them look less intense and staring. Recently had a patient who was crying in my office. She was a grandmother, and after we fixed her eyelids, she said her grandchildren, first time in 4 years, actually came to hug her. They were not scared of her, and that brought tears to my eyes too. So this is a woman who had decompression, did not need strabismus surgery, but did have upper eyelid retraction surgery. Again, decompression, upper eyelid retraction surgery. And then we can get to the cosmetic stuff, the stuff that probably is not covered by insurance, or at least your doctor has to really go to bat, and oftentimes it still gets denied. But things like neurotoxins, so the Botox, the Dysport, the injectable neurotoxins, the dermal fillers. Patients with thyroid eye disease, after living through years of, that's only going to ring 3 times. After living through years of squeezing and pain and discomfort, they tend to get these lines, and the lines that people get who do not have thyroid eye disease, but they tend to get very deep lines that make them look very angry, very tired, and they hate the way that looks, in addition to everything else. So that's something that can be done even when the disease is active, to try and relax the muscles and give patients a little bit of help and let them feel better about the way they look. Right. So this is Botox in a typical cosmetic pattern to relax those 11 lines, those bunny lines. We can even use fillers. So the fillers that we normally use to give volume to the smile lines, the cheek, the temples. Well, we can actually use the same stuff and inject it into the eyelid muscle to lower the upper eyelid and raise the lower eyelid. So this is that same woman I showed you earlier with the upper eyelid retraction. Well, we can put some filler in there to bring her upper eyelid down. It's a very small amount. And this is immediately after filler was injected in her right upper eyelid. And this is 10 months later. So it tends to last a long time. It can be a good temporizing measure. If we're still waiting for things to get stable, that's not a bad way to go. This is filler in the lower eyelid. So she has lower eyelid retraction. Her insurance would not cover this because it's not causing vision problems per se. So she didn't want to pay whatever it is, $10,000 out of pocket to have lower eyelid blepharoplasty surgery. And so a little bit of filler to raise the lower eyelid and to just kind of hide the fat bulges goes a long way. So again, filler to the lower eyelids in this young woman with mild disease, filler in the right upper eyelid and right lower eyelid just to improve the symmetry. So together we can get through this. It's a multidisciplinary effort between the oculoplastic surgeon, the endocrinologist, the radiation provider, rheumatologist, and most importantly, the patient and their friends and family. I'm going to give you my contact information along with email if anybody wants to has any specific questions that we don't cover. If this slide ever pops up. There we go. So the website is my private office, and then this is my personal email. You can always reach me. So we can get patients back to where they were before, or at least closer to it. It just takes a lot of time and patience, and thank goodness for the newer medications that we have access to now.
Thank you so much, Dr. Chang, for that great presentation. We've had a few questions come in. The first one I'll ask, this person says, I have type 1 diabetes. Can I take Tepezza?
Yeah, so one of the side effects of Tepezza is hyperglycemia. As long as your diabetes is controlled and you're under the care of a primary care doctor and an endocrinologist who's following your sugars, you should be fine. Because in the clinical trials with Tepezza, the hyperglycemia was not like blood sugar levels of 800 going into the hospital, in ketoacidosis. It was not. So in the first clinical trial, the levels were up to about 300. And then that's when they actually realized that this was a possibility. And once they figured that out and kept patients on a tighter regimen, whether it's oral medicines or insulin, if they were already on it, the second clinical study, the blood sugar levels, even when they went up, we're talking about like 150, 180 type of levels. So it's not the dangerous level if you as long as you're, aware of the possibility and your doctor is working with you on it.
Okay. And Layla, this one's for you. And a few people have asked some questions and you all have answered, but I feel like for the benefit of everybody, we should hear your answers. Layla, she wants to know about your twin. Does she have Graves or thyroid eye disease?
So no, I had such an extreme case when I was 11 and 12 that they just figured if her twins, go ahead and just check her. And she actually had slight hypothyroidism. So she didn't have the eye disease with it. And she's been stable since she's been 12.
Okay. Dr. Chang, someone asks, they've already taken a full round of Tepezza. Is it possible to take a second round?
Yeah, it actually is. And the clinical trials are the results of the clinical trials are starting to come out about patients who did not respond to the first course. Those few that did not respond, if they actually got a second course, a significant percentage of them actually did respond. So it is possible to have a second course of the treatment, depending on your specific clinical scenario. It's probably, again, if it was hard to get it approved the first time, it's not going to be easy the second time around. So that's an issue, but at least from the medical perspective, yes, it is possible to have a second round of treatment.
Okay. And then this person asks, I need surgery for my crossed eyes. My doctor thinks my TED is stable, but I'm worried I will need additional surgery if it's not stable.
So I think that's going to require communication between whoever's going to do the eye muscle surgery and whoever's managing the thyroid eye disease if it's not the same person. So they need to be on the same page that your thyroid eye disease is stable. And that's repeat measurements, watching over time, all the proptosis measurements, the clinical activity score. And once everybody agrees that you're stable, the eye muscle measurements. So when they measure how much to move the muscles around, those measurements need to be stable for at least 3 months before the eye muscle surgeon is going to do the surgery anyway. So I think you're going to get a dual, multiple check mechanism to, as best as we can, make sure that you are stable before you get the eye muscle surgery, and recognizing that, there is a chance, that 5 to 15% chance that you can reactivate and have inflammation down the road. But with, who knows if that's even going to happen, when that's going to happen. So that would not be a reason to hold off on surgery if you're living with double vision.
So that's a great kind of segue into, oh, sorry, Layla, did you want to say something?
I was just going to tell Dr. Chang about the hefty price tag for Tepezza. They have a really good program that they actually do like copay cover.
Mm-hmm.
And they help you navigate through insurance as much as you can based on what your doctor sends them. Mm-hmm. So I know that it took a few months to get it, but I have had zero out of pocket after my insurance because Tepezza has had, because it's a new drug, relatively new drug, and they want people to be able to pay for it because it is very expensive. But just so people do know that the patient advocates of Tepezza, I would talk to them about just different options and letting you know for your patients' purposes, they've really helped me get my insurance on board.
Yeah.
Great. So, Dr. Chang, someone has asked, does thyroid eye disease lay dormant and then kick up again?
I think that's probably in that scenario that we talked about with the reactivation. So again, about 5 to 15% of people over their lifetime can reactivate. So they've had thyroid eye disease once, everything stabilized, normalized, and then at some point there's usually associated with some kind of stress in the body or in the environment or in the emotional stuff. So some kind of stress happens and then you can reactivate. That's 5 to 15% of patients.
Yeah. And Layla was in
I
that
was
5 to
one
15%.
twice.
Yes, twice.
Rare the first time.
Can children develop thyroid eye disease?
Yes, there is pediatric thyroid eye disease. Tepezza is not approved for patients under 18. So we do end up having patients having young children with thyroid eye disease that need treatment. Fortunately, they tend to respond well to treatment, the more traditional treatments that we have with steroids. And so the disease tends to normalize, and thankfully we're not doing a lot of orbital decompression and that type of surgery on young children.
Okay. Can thyroid eye disease be passed on to family? So to children, can you pass it on if you have it?
It's not like what we call an autosomal dominant inheritance. It's not like one of those things where if you have it, it's for sure that your child's going to have it, or even that if you have it, there's a 25% chance that your child has it if the father has it. So it's not inherited in that traditional way like genetic diseases. But we do know that certain families are more prone to autoimmune disease in general, right? So you have mom with sarcoid, and then you have somebody else with thyroid eye disease or rheumatoid arthritis. So there is a hereditary kind of predisposition or propensity to having autoimmune disease in general. So that can happen where multiple members in a family have either thyroid eye disease or some other form of autoimmune disease.
Okay. If you have thyroid eye disease, are you more susceptible to other eye conditions?
That's a great question. Not insofar as you have thyroid eye disease, so you're more likely to develop glaucoma, 10 years later. But it's that when you have thyroid eye disease, there's so many other things that the disease itself can affect so many parts of the eye that it's almost like you have another eye disease, right? Because you can get things that seem really a lot like dry eye syndrome, with all the exposure and the grittiness and the dryness. If you have a lot of pressure and congestion in the eye socket, some patients they have a picture that is confusing with glaucoma, because glaucoma is also pressure in the eye that can cause optic nerve damage. So yeah, there are many different kind of manifestations of thyroid eye disease the eye disease within the eye itself that can mimic other eye diseases, but I don't think it makes you more likely to get diabetic retinopathy or macular degeneration or anything like that.
Okay. Someone asked, what can be done to help with eye pain? I get headaches from double vision and equilibrium being off. So maybe both of you would want to weigh in on that one.
Layla, do you want to go first?
My eye pain was prior to Tepezza was dim the lighting. That was a big one. Like Dr. Chang said, I wear an eye mask because my eyes got really, really dry. I actually had to have my tear ducts plugged in dental school because stress and reading, it felt like I was going blind. And so to speak of that, I thought I was losing my vision, but it was just that I had so much dryness. Even though my tears were producing, it was the bad tears. It was the ones that were causing it. So we had to plug that. So mine was just around my environment. I had to change a few things to live with it. And I was able to live with it comfortably for years prior to having Tepezza. So, I mean, you just have to have your family and friends to understand that you can't have super bright lights, and they may think you're being a hypochondriac and or over, compensating. Like, I mean, I would do this and my husband's like, seriously? And I'm like, I mean, I realize you're judging me, but like, this feels better to me. Feels better to me. So that's the patient side of it.
Yeah. The pain, if you're talking about kind of that deep aching sensation behind the eye, that's really hard to treat. Without either some kind of medication or orbital decompression surgery, right? So as far as on the medication spectrum, if we're not taking an IV steroid or using Tepezza or one of these other drugs, I've sometimes actually just injected steroid into the orbit to give some local anti-inflammatory effect. So that's a possibility. If the pain is actually headache related to double vision and eye strain, so some of those strategies that Layla was talking about can be super helpful. And then just patching, and I know it looks weird, I know it's annoying because you don't have your peripheral vision and you don't have your depth perception, but just eliminating the double vision can help.
Right.
I think just two more questions and then we'll wrap up. Layla, they're asking, did you exercise when your thyroid eye disease was active? Did you find that to be beneficial at all? And I'd be curious too, just kind of also from the mental health perspective of things, if staying active can help patients who are battling this.
I guess it would depend on how much pain or discomfort I was. Like I was saying before, I didn't realize that I needed as much relief until I got it, because you just compensate for what you're already used to. So I did, but I have kind of comorbidities. I'm an asthma, exercise and heat induced asthmatic. So that added more stress, which then caused my eyes to be more dry and then pain. And, it all just correlated with one another. So I did mild exercising, which was walking. I didn't do anything super strenuous. I would do like light dumbbells. Even I did that beach body, and every time, Sean T's going, do more, I'm all like number 1 to his 10. But I did stay active because it did help me. It was just my version of active. And we all have this shame and guilt and all these things that we do to ourselves, which is why getting the right support system was helpful for me to like not judge myself.
Dr. Chang, what do you recommend to patients?
I think it's really important to stay active. I think, like you said, the mental health aspect of it, and just we know that exercise and a healthy diet do wonders for the inflammatory kind of environment within our bodies. So I think having, and it doesn't have to be super intense CrossFit, whatever exercise. I think walking is a great thing to do, walking at even a mild to moderate pace, a few times a week, some light resistance training, and then just eating healthy and avoiding smoking and secondhand smoke.
Great. Well, my last question was going to be about diet, but you just kind of talked about it right there. So I think that's all the questions that have come in today. So Layla and Dr. Chang, thank you so much for joining us today. Layla, thanks for sharing your personal experience, and Dr. Chang for that very informative presentation. Everybody who attended tonight's webinar will receive a recording of this, and we appreciate everybody hopping on and hope everybody enjoys the rest of their evening. Thank you.
Thank you.